So we're finished discussing supervised living, supported living. I went the wrong way. Crisis services. We titled this one, I Will Be Safe in My Community. And right now we have crisis services definition, which is a tiered approach. Primary crisis response, behavioral consultation, and out-of-home crisis. And I know we've had challenges in our area with this service. And I think there's been challenges throughout the state with this service because of the tiered approach and the lack of understanding around that. And we haven't proposed anything new for this. I know there's initiatives statewide around crisis services. So I guess it's open to feedback.
You're a brave man.
Not really.
Who was to do first?
What do you think, Jamie?
You.
No, what do you think?
What do I think? I think Jesse nailed it on the head.
Well, I can step back. Some of our challenges have been around the understanding of primary crisis response. Because within the waiver as it's written, there's the expectation that if you're providing residential supports, in-home skill building, in-home intensive supports, or personal care, that you're expected to be the first responder, so to speak, for that person, whether you're providing that service or not. Now that's somewhat problematic in the IDV world because there's no rates associated with it, unless you have primary crisis response in your contract, and then you have a unit rate that you can bill. But there's a lack of understanding around that. I know there has been in our area, and that's partly because of the differences between innovations and CAP that we still have not really remedied. So there's my thoughts about it. Fixing it is making it very clear that every provider of certain residential services has this embedded in their contract. That's one of the steps we're taking in our area. So, problem solved. We can go to the next slide, right?
Your last point there is really a structural deficit we've been trying to have recognized for some number of years. If you are going to expect functions to be performed, you have to pay for those functions. In ICFMR, for example, we do have a kind of a medical home model that is integrated care. We have with our people with mental illness and substance use, we do have those service definitions in CABAs that can go with that function, but some of the CABA functions are not necessarily paid for adequately for the performance of those functions to be the medical home, so to speak. And then you get to the innovations where you just mentioned. Absolutely not. We've got to structure a whole. We do not pay for innovations recipients to have that medical home for the agency that would be responsible for them. That is something we need to fix this go round. Who is that going to be? What is the relationship between? Right now, if you just get a few hours of innovation services, and you were to get a call in 10:30 on Friday night, as happens, and he's the first responder. So we've got first responder issues that we have to resolve. The Crisis Coalition, another group, really doing some innovative and some good things. Of course, there for IDD, the NC START model is the one that is big. There's 3 right now. So you can't have just that 3 in a state situation.
But with the
that's right.
But with the NC START model, the current definition as it is does not crosswalk to the services, and I think that we need to look at that.
That's right.
Those two together.
Well, what we've ultimately got to end with is now we can't even have resources within MCOs, LD MCOs, because they're originally really regional systems. I mean, how many square miles do you guys cover? A lot. So we've got to have these solutions. So this is on track. we've got to have these solutions that are available in every county to some extent, and much improved. One thing that came up at the last meeting too is that what crisis is for a person with intellectual developmental disability sometimes is very different than a person with mental illness. If the staff doesn't show up, if a parent dies, or whatever life-changing event happens, they can really be in crisis. And it's a different kind of crisis and a different kind of crisis response that we have to develop if we're going to really serve our IDD folks.
For sure. We happen to be the middle part of the state and provide the NC Start services here, and it's always amazed me that we don't fund it with waiver dollars. It's state-funded dollars as started as a pilot, and then it's expanded across the state. We do start here at a certain budget. In Virginia, we have about 50% of the state with REACH. It's called Start, but it's called REACH there for other reasons. And the budget's about twice as high there because of the need, and it is a DOJ lawsuit settlement case. So that's probably the difference. But it has amazed us that we can't get, and Vivian has worked with us for years trying to get this into the waiver. Is only about 25% of folks with IDD come into Start Crisis, and we still can't get a crisis funding authorization or an add-on to a plan of care. So we don't bill here. In Virginia, we have.
I'm just curious.
We have never figured that out. In Virginia, we have 4 dedicated Medicaid services we do.
Is it because you have to have it dedicated? I mean, I don't understand, so when started out, RHA runs it in our neck of the woods.
Right.
I did everything I could to try to beg them to take the money, and they wouldn't.
Right.
Not a slam against RHA, tried to fund additional position because there weren't enough, gave them $50,000 the first year to do that. Begged them to let me buy beds specifically, wouldn't let me do that. I mean, I did everything I could, short of going up there and handing them a check to try to make them take our money, and they wouldn't, and still won't.
Oh, really?
Yeah, actually withdrew from our network about a year ago.
Oh.
So even if you did have a Start definition right there, they wouldn't be able to bill it in my MCO. Just as an aside. I don't know why. We withdrew from our network as a DD provider.
Oh, really? Who's your, do you
I
have a
might
Start
want to talk to
provider?
Sandy.
Just saying, I don't want to get into
Cindy.
that, but I'm just saying,
You
it's,
might want to talk with
If we
Sandy.
can talk about
Do
that
you
later.
know
I'm
why?
just saying, it's really interesting why, I don't understand that myself.
Well, no, do you ladies know why?
That is the first thing I've ever heard, and I've overseen Start statewide for 5 years. It's now transitioned to DMH, but that's the first I'd heard they had pulled out.
They're not enrolled, the provider's not enrolled in our network.
Well, yeah, but.
Well, they don't have to be for
Yeah.
Start
Not for
because
Start.
it's all
No,
state
right, but to
funded.
bill, they would have to be.
Gotcha.
Yeah,
Right,
I'd
and
have
so
to
what
be
I'm saying is
involved.
I personally have met with them and Joni Beasley and said, why don't you bill these crisis services for these inpatient
Well,
people when we put them there? And they
I-
don't.
I will tell you, Cindy, that it's very complicated to build the Start model with this because the other regions have tried to do it as well with the MCOs, and they have a hard time getting it through UR.
Yeah, it's been a hard, difficult thing with UR in some of the.
Nobody's ever asked.
Why?
I've asked them to do it, and they.
Yeah.
So now it's time. The conversation's happening.
Yes, sir.
3 quick things. One is that for about 5 years I did a lot of consultation with the North Carolina Hospital Association, specifically around folks who had IDD who were winding up in emergency departments. That was one of the areas. And the numbers were a whole lot higher than I think what most people think they are. And I think we've got still a fair number of folks that are in crisis, but they're in crisis in an emergency department. They're not in crisis in our system. And
But our staff are sitting in that.
but
with them.
exactly, exactly. That was kind of my point, was that it's still being responded to, but it's not a very effective, it's not a good use of staff time, it's not a good place to get well, for God's sake. So I really think, especially, we need to start capturing some of that kind of information and understanding so that we can respond and get people back out of emergency rooms, but also to prevent them from having to go there in the first place. So I think we've got to shift some thinking about when somebody has had one crisis, they don't have to fail 3 times before you have a prevention plan. And I don't see the word prevention up there at all.
Actually, it's
and-
part of the behavioral consultation.
Great, super.
Piece of
Glad
that.
to hear it. So, and the last thing I was going to say is that one of the things nationally that has killed most of the crisis services is an artificial UR process that is contraindicated for people who are in crisis.
Yes.
And you don't have to have a UR review to call an ambulance. You should not have to have a UR review or process when you've got a system and a process in place to address crisis.
And that's very true. And the way it's set up now, technically, a care coordinator should be able to authorize crisis services, but that doesn't seem to be completely understood throughout the system. And then there's also challenges with regard to the UR piece because of expectations that it has to meet certain crisis criteria that it doesn't necessarily sometimes for START. And START, one of the other challenges with funding START is that there's no way to pay for the START specialists because the majority of them are QPs. The definition that we have with qualified professional, the definition that we have for specialized consultative services doesn't currently allow for us to pay for that through specialized consultation. So those are some holes too that I've noted in discussions. And the rate for our out-of-home crisis throughout the state is not sufficient to meet the need either. So that's another challenge. So there's great gaps in this beyond the primary crisis response.
And I think through the way in which the service definition is currently written, it alludes to behavioral pricing and behavioral only. So I think somebody was speaking earlier about medical crises and every time care passes away and so forth, but there's different crises for different individuals, and what a crisis is for me varies from person to person. But I think it speaks a lot to more of a behavioral or even a mental health type of crisis.
One of the things we talked about at last, 2 weeks ago, was having a pass-through on the definition.
Yeah.
We talked about that.
Yeah, we did.
Right now? No, we haven't today though, right?
No, we have not today.
So it might be nice for you to consider in your definition when you write that, a pass-through, like a certain number of hours, whatever it is, page 24, before the plan or whatever has to be done to offer it. So it's the provider knows they can do up to 24 hours in this before authorization has to be rendered or card has to be submitted or plan has to be revised.
I think that's in
Well,
there now
it's-
in 3 days.
You still
Well, whatever
have
it
to put
is, yeah, whatever it is, but it doesn't happen right now though, right?
Yeah, but what happens right now is,
People are scared they won't get paid because they don't have a TAR.
right,
Or
you
TAR,
can-
whatever you call it.
you can get the authorization after the fact right now, but it's,
So we'll tell
I
them
know,
that
you
trying to
can
keep
if
It
you-
might get denied. So a
Yeah.
pass-through
And
is
they do
different.
get
Exactly.
They do get denied.
and
Right,
it
that
should
wouldn't
be.
be a true pass-through.
Don't-
And I think
yeah.
just to, and so I'm gonna ask that Cindy be the last comment, we move on, because we've got some other big ticket topics coming up, not for nothing here, so I think we'll have a lot of input in. But I will say that, and this is not to say that please send us your feedback as you have been, for anything that we don't get to today. But yeah, that would be different. The other thing that we need to talk about, and not necessarily in this context today, but as part of like this group and our ongoing efforts, is going to be training and shaping culture. Because what we're talking about here is a huge culture shift it's going to be a huge culture shift. It's going to take some time to get that through. So that's a much bigger, I think, not just in terms of pass-through, but in terms of like your all of your definitions, just the way we're looking at this in general, just the individualized budget concept, it's going to be a huge culture shift. So can we move on to day supports? Which, by the way, just as an aside, when we come back and look at the budget, I'm sure that those of you that tuned into the webinar heard day supports, the one-on-one day supports is one of your huge money drivers. and there's a very minimal use of any kind of group day support.
Yeah. Oh, you mean right now in the system based on the
Yes.
current data?
Yes, so I'm just gonna remind everyone of that piece of information as part of this discussion.
So under day supports, there is kind of a adult day health and developmental day. Developmental day is intended primarily is intended for children for after school care as well. But it helps, again, it's somewhat of a blended service, if you will, where it's supervision, teaching, socialization, and it also, in the adult day health arena, focuses on pre-vocational skills as well. And this is a service that has not been discussed as of yet. One thing I think we did discuss at one meeting was the way that the current service definition reads is there's no information that talks about the developmental day portion of it. Other than I can give you one little sentence in there. So it needs to have a little bit more of a focus on children.
Focus on children, not on adults?
For the developmental day portion of it, yes ma'am, because like I said, it can be delivered for children for like after school care, but there's no guidelines within the current service definition regarding that piece of it.
So it's probably hardly even used. Even, and it's not, because there's not licensed facilities, because that's the other requirement, right? You have to launch from a licensed facility in this definition.
I think we have one, maybe two individuals out of close to 300 using it.
Right. But it is available.
The launching from the day facility,
And
licensed facility thing, has come up as an issue with one of my agencies that has someone who has a real job and they have to drive for 30 minutes to the licensed work setting, and then they have to drive 30 minutes back to their work. And it makes no sense. And you need to think about people's needs, back on the flexibility thing. Whatever the intent was, I guess that you wanted to have qualified providers that were licensed to do day services. We definitely need to have some other component in the system that allows that provider to be qualified, that's doing the right thing for this person based on their job. It's very person-centered. If we're going to say person-centered, let's walk person-centered with some flexibility and those kinds of things. Some other kind of process that allows that to occur.
I think the statement you're talking about in the service definition, it reads that the service must originate.
That's right. That's right.
And
Exactly.
based on that one word is where all
Yes.
the confusion stems from and issues. I think everybody's trying to wind down or.
They're all exhausted. I will just
And again, that's perfectly fine. We don't expect to receive all of your feedback today. So this, again, is just an overarching discussion, and hopefully you guys will be able to have an even more in-depth, detailed discussion about each service and really get into the service definition.
I do think before we move on to supported employment, I just have to make the point again. I know I made it cool, but like thinking about what it is you want day supports to look like and what it needs to do. Because again, this is where a lot of your money goes right now. It's on this service. So,
On individual basis.
on individual day supports as opposed to group, correct?
But I don't think there's any established group organizations like the equivalent of like a YMCA program after school. And if there was, then it would obviously be desirable for a lot of children to attend because socialization is always a big issue and everything can be done cheaper in a group, but then you also have the benefit of contact with other children, and interaction.
Right, and if I'm not mistaken, I'm 99% sure for developmental day, it's actually an individualized service, and then for the day supports, there's group and individual. So that would be just, there's currently only a group definition for adults under day supports.
But I hear her also indicating there's network capacity issues.
And then there's network
And I don't think there's anywhere to go
For adults?
for children.
Right.
Correct.
And there's very few things for adults. I don't understand why there's not a way bigger emphasis on creating locations for children and adults because I mean, I don't think the world benefits in isolation, and especially with disabilities that have social issues. The more, interaction, I'm not saying it's constant, but group is always cheaper, and it also has benefits. Whereas you're living your life in isolation, or just bonding with one adult caregiver, doesn't do anything with developing peer interaction or anything beneficial on a social level.
Right.
Plus, it's super pricey.
Yes, it is. As the checkbook in the room, yes, it is.
But how come there aren't, why isn't the definition to incorporate group? And also, I guess there should be kind of some sort of letting people know that this might be a good thing to create.
For group or?
For group.
For day support. And the way,
Like after school things, like the Y program, just something like that where they can get the kids from school and then they can do stuff and whatever, and then their parents can pick them up, like normal after school program.
so the way the service definition currently reads for day supports is it is intended to be delivered primarily as a group service. That's actually the very first sentence within the service definition. How that's actually being carried out and delivered by individual agencies, I can't really speak to.
I'm not aware there's
but
any
we
day
actually-
programs for.
And that's for adults, and then for children, again, I think it goes back to a shortage and a capacity issue. Which we have
Right, we have it.
indicated on our board. Jeff, do everything else you would.
I looked like I was going to say something,
You
but I
didn't.
thought better of it. I used a filter. Imagine that.
I think-
No, I was going to, about the day supports piece, I think a real part of the challenge is that it's facility based. And the license and everything that's tied to that. And some of the things that we've discussed regarding day programming and after-school programs, that can actually be accessed through the community networking service definition if there's a better understanding of that definition. Because, in my mind, the way the world should work is that YMCAs that offer after-school care for any child should have a number of disabled children that come, and we send in some staff to work and add additional support for the children with disabilities in that setting. But that's getting on to community networking instead of just thinking about day supports and developmental day and the whole facility concept. Based on decisions at the federal level and other pieces, it's a good possibility that it will not be.
So that's why your capacity's not gonna be built, because people know that.
And it is a very, it's, the rate for this service, the individual service, is the highest habilitation rate we pay at Smoky. And that's because it encompasses transportation, which we're regularly told is not enough for the transportation. So it's one of those challenges because we really got to start focusing on community capacity in programs that already exist for persons without disabilities. I know you're with me.
I will tell you right now, that is why it is that's why that's the most billed kind of service, is because that's where they get the most money. Why else would they be billing that service more than? It's not rocket science. And I mean, I understand that, I'm not saying that people always erroneously bill services or anything like that. All I'm saying is the way that the system is now, there's a very, very, very high correlation between the most utilized services and the services with the highest rates. And I don't think that the rates are that high because they're used that often. I think it's the other way around. And I know we're going to talk about rate setting, but that's something that really is a big issue for me because it turns people's lives into how do we kind of sort of give these people what they're looking for while making the most amount of money we can make. And I'm sorry if that offends anybody, but that's the way that I see it, and it's a problem.
Speaking of money, the next service That's right. So this definition provides individuals with the support that they need in order to acquire or maintain competitive employment. This current service definition is actually a blend of supported employment and long-term vocational supports, whereas in years past, they were together, and then they were separated, and then they were back together again. I think, based off of a lot of feedback and observation, that I have seen is the whole competitive employment portion of it. And then also actually the blend of the long-term vocational supports and the supported employment. Any comments, questions, concerns?
I know the one that has come up in a couple of provider meetings is that 3-year experience for the staff. It's just hard to find, particularly in rural areas. To be able to do that, but it creates a capacity issue, so you might want to look at that. There's a requirement around 3 years full-time experience, supported employment to be able to be a job coach, basically.
Yeah.
And that's hard to find, especially outside of Lake County.
Yeah, it's hard to find anywhere.
That actually brings up something that I would say is an issue overarching with the waiver, and that's that a lot of the regulations for people being able to provide the service are really prohibitive for any type of qualified workforce, but especially, and this is something that I've talked about a lot in meetings, I think some of these definitions could be well served by other people with disabilities, but the way that it works right now, there's so many licensures or regulations, you need this education or that education or whatever, and I understand why it's there, because they want to make sure that the people who are getting these jobs are qualified to do them. But for crying out loud, I think we can use more common sense than there is now. In, who gets what jobs and who is quote unquote qualified to fill a certain position. And it's not just true for people with disabilities, but I think it's especially true for people with disabilities. But it's across the board. I mean, there needs to be a happy medium between making sure that somebody is qualified and making things so restrictive that pretty much nobody is qualified unless they spend a significant portion of their lives going out of their way to get qualified for just one position. And then what happens when they're not in that position?
Because that's one of the biggest complaints we get. Another, you already mentioned the issue with long-term follow-along, and that's a problem we see, because folks will reach a certain skill set with a job. They're going to need a level of support, indefinitely probably, to maintain that job. So you need a differential in rates to make that make sense sometimes. And right now, we do not really have that in our area, because we're paying the high rate even when the person is at a point where they're just needing supported in that job. And it's thinking about our whole service array from the perspective of support and not constantly and always about limitation that would help with regard to that piece.
But on the flip side, the way some MCOs would manage that would be on the UR side or UM side, and therefore then they lose, the hours and they lose jobs, and now we're back full circle going.
Exactly, because, and it just doesn't make sense, because you do reach, well, it's like, the mention about common sense, but there's nothing common about common sense, right?
Unfortunately.
Or on the flip side, you have individuals who receive supported employment for kind of an indefinite period of time, and they're doing all of that kind of pre-vocational
Right.
for
Well, pre does mean never.
So anything else about supported employment? And then the next one's community guide, which I think we've actually discussed in depth, so I don't know if we need to.
Before you move off that, so for competitive employment, is that to me competitive like minimum wage, not piece rate, right? Not piece rate, because that's a big national debate, you know. So, just for clarity, we're meaning competitive employment, meaning at least minimum wage.
And can we, you know, the other thing, I think this is in the definition, but not have contrived employment either.
Thank you.
So where somebody creates a receptionist position to hire the person into that they wouldn't otherwise have if they couldn't build supported employment on them. So not contrived employment, that might be in the parentheses. Just make sure we don't lose that.
Don't lose sight of the fact that it needs to be real.
It should just be real competitive. When you think of competitive employment, it's not like Uncle Bob made a job book for you.
Yeah.
It's
called make work.
So, okay, so let's get past community guide, because we've really painstakingly gone through this. And move on to your community networking definition. I don't hear anybody saying, oh no, please, let's go back.
Don't want to go back to community.
You missed that day.
I did. I'll miss the rest of the days. This is my only day here. So, community networking. Choose what I do in my community. Individualized day activities that assist in promoting participation in community life while developing natural supports. The ideas behind this service definition are really, I think, what the system should be moving towards. But it's very different from the mindset that we've had in previous waivers. I mean, I remember the community component of home and community supports, I'm sure all of you are.
Community inclusion.
Exactly. And a lot of folks still think that the only way to use community networking is a volunteer activity. But it's not. It's to be doing things to embed a person in the community so that people in the community start including them without the supports sometimes. Sometimes it will not happen, sometimes it will. And that's a real thought shift. And I'll be honest, it's one of those things that it's going to be more difficult for me to do than it's going to be for my stepson to do. Because, you know, I was in school when IDEA was passed, and so integration started when I was in grade school. My son has been in grade school, or was in school his entire life with integration. So he sees people with disabilities very differently than I do. And it's going to be easier. It's one of those things where the moral arc of the universe is long, but it bends towards justice kind of things. And this is what this service is supposed to be doing. And that's why I mentioned like the programming after school. What we should be doing as MCOs or care coordinators are seeking programs. I guess really community guides should be doing that. Seeking programs that are willing to offer so many placements for people with disabilities so that they can create some more inclusive settings. Yes?
Yeah, I just wanted to comment on what you were saying about things being better now than they were. I grew up in northern New Jersey, about 20 minutes outside New York City. I'm going to try to figure out how to phrase this properly. I will just say that based on stories that I've heard, granted I've not spent a whole lot of time in North Carolina public schools, but from what I've heard and what I have seen in terms of occasionally visiting schools to speak to students or things like that, I will just say that where I grew up, I feel was a little bit further along that moral arc that you spoke of in terms of integration and students without disabilities having sort of a more natural understanding of students with disabilities. And I guess what I'm saying is I'm glad to see that it is moving that way everywhere, but I can also attest to the fact that it is something that does occur because I've been somewhere that was further along than where I am now.
Well, every region evolves at its own pace, right?
That's a good way to put it. Thank you, Jesse. I appreciate that. I was looking for the right word.
One other,
Did you have a comment?
I do. This service for adults with severe and profound needs, once it was taken away from the relative/guardian, those families stopped using this service because they are incredibly uncomfortable with the idea that some staff is going to determine a natural support. It needs to be vetted when you're at that severe and profound end of this population. The guardian, the relative, you just can't. It's a big problem.
That's a very valid point, because everyone brings their own vulnerabilities in
And
each situation.
these aren't, and children and schools and all of that is one issue, but when you're talking about 30, 40, 50-year-old adults on the severe, profound end of this range, a lot of families, and it's brothers and sisters doing for brothers and sisters community networking and getting that natural support. So now if there was still a parent who was alive and involved, then there was some sense that, yes, this natural support is something, because it was vetted by a family member. So you just, there's a whole range.
and one other, or some other feedback that we have received regarding service definition, and it goes back to, Jesse said something, but I can't remember what he said. After he talked, my brain is shutting down.
I didn't know I said something.
But it was profound.
You did. It was very profound, whatever he said.
It's a shame that the one time in your life that's happened, nobody can remember.
Mary has it on
I was going to say, we can rewind the tape.
Unfortunately, everywhere I go, I'm on videotape.
I know, it's hard to tell who's on my site more, Jesse or Dave.
I actually do remember, it was where he spoke about the service is primarily used for volunteer work.
Yes.
I think in the current service definition, it's a list, and that gives you ideas, but at the same time, it also eliminates some other potential possibilities, because a list in and of itself indicates that you can do these 5 things and that's it.
Right.
So just some kind of food for thought.
Yeah.
Okay.
The anti-list club.
Yes.
And it goes back to providing guidance, yet flexibility.
Right.
Maybe we can handle the list through education.
You know, that's, like, I think sometimes a list goes both ways, because often it's to plant seeds in folks' head about what for ideas, but UM tends to look at that list and say, oh, you can't do this.
And so do auditors.
Yeah, you're right. So it's,
Yeah.
lists are difficult. Manage my services. This is best practice in the field. Employer of record, allowing a person to take responsibility for their services, to have as much control over the funding that's supporting them in the community. And it works, it's working really well for some people in this state. We're actually moving into it with some families in my region, and it's challenging because it's very complex the way it is now, and I know we need to simplify it in some ways. Individual goods and services allows families that are self-directing to purchase certain items they wouldn't otherwise be able to access, especially if they do not have the funding. And the financial support services just creates a payer for us to move the money through. Right now, families have to manage and control, go through the same processes and steps that any provider does. To self-direct, there's a manual that's about 50 pages long. It's almost too complex. So that's some of the feedback that we've received, and believe me, in trying to put it together to make it work in our area, it's becoming very clear how challenging it is. But this is something we've got to figure out a way to make it easier and more attainable for other folks. That's my feedback about this. Because people are more accountable with the dollar when they have control of it. And I think like one of the things that I sent to the listening sessions is do away with the term individual budget and call it supports account. Because that implies that you're going to get what you need instead of being limited to something that doesn't. So we have to take the system more in this direction, and with changes that are occurring because of the companionship laws and other things and joint deployment, this is going to be the way of the future. Any other comments about self-direction? Did I sum it all up?
Can I say the only question I've had from families that have asked me about it? They seem to think that it's the existing rates and the services you are using, that becomes your budget if you're doing the employer of record or the agency with choice. And I've told them that that's not true. If you look at your current innovations budget for your PC and your in-home skill building and your day supports and whatever that gross dollar amount is, that does not become your budget when you go to either employer of record or agency of choice. They take some money out of it because there isn't that agency expense.
Well, it depends on...
And that's the only way I can explain it, and it's different with everybody, and
it is.
I said you need to just do it.
An agency with choice, you still have a lot of the overhead. The providers still have a lot of the challenges that a provider-directed supports provider would. With regard to employer of record, there's certain things that have to come out of the rate because of federal law.
Correct.
All of those things total roughly about 13.45%.
Roughly 13.45, okay.
That has to come out of the rate that we're paying before
You're
the
funny.
family pays. And then you have to set some aside for different things. But employer of record within the existing rates gives a family the opportunity to pay staff better.
Yes.
I say that grammatically accurately. I
No,
don't say a lot
it
of
sounded
things
good.
correctly with regard to grammar because I'm a good old boy can become an intellectual, but an intellectual cannot become a good old boy.
Well, that explains a lot.
Let's go to the next slide.
I'm telling you, it's hard to find a good comedy club.
Remember to tip your waitress.
What's in that bottle?
Oh, we all woke up.
Water or something that looks like it.
People are fun.
So this is one of the two services that we lump under the education category, if you will, and that's worth education. And this is intended to provide feedback and education to natural supports of the individual to help them understand the interventions and strategies that can best be used with the individual.
This is not a big ticket item.
Right.
It's not a big ticket item, but it needs to be more easily accessible because I think sometimes UM gets in the way of this.
Yeah.
Just because of some of the details and the billing mechanisms and all that.
I know that part of what we talked about being in our combined definition, sort of, but Jamie and I talked about this before in a different situation where it would be really good if anybody kind of coming into the waiver automatically got this, for instance, you know what I mean? So then they could kind of understand what do they need to do, or at a period of transition in their lives, kind of connect them to some of the,
Right. And I think there's also been some
orientation.
There's been some confusion about where does the kind of day-to-day QP responsibilities end and where does natural supports education start? So there's not a,
Oh, yeah, I see that.
there's confusion surrounding that.
Hmm.
I think I need a drink of whatever you're drinking. Next. Specialized consultative services?
Well, we've mentioned this, specialty topics. I mean, this is a way for the team to access specialty providers for speech, physical, occupational, behavioral needs. This is a place where we could really probably increase the ability of START to access funds by including START trained coordinators in this definition. You know, because right now it's pretty well limited to other fields that have some type of credential. Well, a START trained coordinator in our field is important, so we should be able to pay for that through this mechanism. We've ran into challenges with regard to positive behavior support plans and the back and forth with different licensure issues. But this is a service that we've not developed enough, and enough people are not aware of it, because it is one of those things that can really inform a team and really change somebody's life if it's put in place for them.
And I think what we've, I'm sorry, go ahead. I think what we've seen it primarily used for would be speech PTOT, but more so the psychologist piece of it, to develop the behavior support plans, to provide the interventions and strategies surrounding that. I think regardless of the specialty area, at least for us, and I'm assuming throughout the state, capacity is an issue as it is with everybody else. Not enough psychologists to go around to develop the behavior plans that we need, and then to provide the training to the staff and so forth. What were you going to say, Karen?
I was just going to say what you run into, and so Jesse, your idea is good. Did we propose that last time? That we got shuffled. Anyway, so you're pulling it back. How many ratings of waiver meetings have we been in? We talked about maybe pulling out some of the softer specialty areas, if you will, and maybe we look at one that's maybe specifically around behavioral, but be careful with that, because that's what we ran into around the licensure and the ECBH. And maybe the other thing that I think I mentioned last time, to be sure it gets captured, is ECBA, be sure that they can provide the behavior consult under the crisis service. Yeah. They can't right now. It has to be a licensed psychologist. But that would help with your capacity a little bit, not much.
Well, and you know, I personally think that we could expand our capacity of psychologists if we allowed QPs to do certain things under the supervision of psychologists. Because I know we have certain psychologists in our area that are willing to do some of the monitoring and the legwork around the behavior plans. They just need that capacity through this definition.
To your point about the QPs on the START model has extensive training for the QPs, plus you have a clinical director, a psychiatrist on the team, and lots of higher level training. So it's not just a QP, it's a highly trained QP.
Yeah, but the way the definition's interpreted, if it's not that clinical staff responding, you can't be with them.
So that has to change.
Well, I think the same thing is true in a variety of other ways, because you can bill for a physician, but you can't bill for a nurse practitioner. You can bill for a physician, but you can't bill for a PA. You can bill for an OT, but not for an OTA. And in those kinds of artificial distinctions, when you've got somebody who can work under the license of someone else, are really not helpful, especially in rural areas where you've got people who are willing to provide those services, but can't without this mechanism. And more states are looking at what are the outcomes that we want, and are they able to work under that license? And if they're able to work under the supervision of, then they should be allowed to provide.
From an outcome orientation.
Well, we're going to channel Sally and say that you can't, that's never going to fly under the Practice Act right now. So,
Carol's back there nodding.
No, I'm in agreement, but I do think, I mean, looking at the START model and the QPs, the key thing there is you've got the competencies that are built in, and whatever system is developed, if you don't have as part of the requirements these competencies,
You have ongoing consultation.
Exactly.
Oh, yeah,
Yeah.
yeah.
Yeah, we just can't call it behavior plan, you know.
Right, you gotta outline what kind of
Right, it's gotta be tight.
competency it is.
Right, and then you also want to tie that back to crisis services, because if we're saying you need a licensed person to do this, but yet we're gonna allow a QP to go out and do that first assessment of a crisis service, you know what I mean?
Oh, yeah.
So let's make it.
It does have to be tied to crisis behavior. Let's see, we have 2 slides left. We've already touched on this one, slide.
Yeah, we have, I can just touch on a lot, but under the different pieces of equipment and supplies that are offered, we have assistive technology, equipment and supplies, home modifications, and vehicle modifications. And this is pretty self-explanatory. What it sounds like it is allowing the individual to acquire the supports that they need in order to ensure that their environment is accessible, whether it's a home environment, the vehicle, or any sort of items that they may need. I know that there's been comments kind of thrown out here and there about the limit of the limitations of cost and the licensing waiver and so forth. So
Yeah, I would really like to recommend for the assistive technology that be annual limit, not the life of the waiver limit, because technology changes so fast.
But if you're gonna do that, would you do it like you were talking about doing with the transitional costs?
Yeah, you could do it that way
For
where
instance.
the first 15,000 of it is outside the budget, and then it's available to you inside your budget every year after that, up to whatever you want to spend, I guess.
Because although you're correct, I mean, you're right, it's constantly updating. There's also, you know, again, Peter to pay Paul, where do you average that out?
Can I just suggest that the word services might be equally valid in there, because there are some assistive technology services that can be accessed that are not equipment or supplies.
Oh, yeah, that makes
That's a good
sense.
point.
Yeah, and that would also include something like
or it could
training.
just be assistive technology.
Pardon?
Or it could just be assistive technology.
Without support or services.
Right. And so this is another one, so I 2 comments, this is another one. All 3 actually have a list, which again, a list indicates that it is exhaustive and no more, no less than this. And again, as technology in and of itself, as it evolves and changes, I don't know that we can keep up with it. And I don't know about y'all, but I don't want to have these meetings all the time to be able to keep up with technology as it changes.
I'll give you the answer to that question. You can't keep up with it.
Right, you can, definitely. And there's a million, I know a lot about assistive technology. There's a lot that I don't know about. And I could never begin to know everything that's out there. By the time I learn everything, it's going to change. So I think the service definitions need to be able to embrace that thought. And then in regards to children, I think there's a lot of, and I don't know if I should open up this can of worms or not, but there is a lot of confusion surrounding EPSDT and how that plays a role into this big picture.
Yeah, well, and some of our definitions we need to bring into this century, because when was the last time you saw a van with a lift?
Oh.
In the back, that's owned by a family member, you know, that's not going back and forth. And our definitions talk about lifts, and we get into battles, gets into battles over lifts and depreciation of lifts and those kind of things. Because the more modern vehicle has the ramp.
But that might be the beauty of the individual budget, what Cindy's speaking of too, therefore you don't have to be as prescriptive as long as you're within health and safety requirements.
Okay, now it's her turn. Now it's her turn.
If that's how you decided to be willing to spend that budget, I mean.
I think there's also some confusion surrounding the professional to indicate the appropriateness of the vehicle modifications. I can't remember exactly what it says in the service definitions or.
Vehicle adaptation specialist.
Right.
Which there is no such credential.
No.
Who those people are, I would be curious to know.
Now, strange would probably be
Cindy,
that
we're gonna make a boatload of money, we'll create enough credentials.
It used to be vehicle adaptations.
I know.
Vehicle adaptations.
Matt had a comment.
Yeah,
Certify you, will you certify?
I just had to say, you know, you were talking about lifts versus ramps. And all I'll say is the only time that I ever see lifts is in public transportation or shuttles or whatever, and about 80 to 90% of the time, they either don't work or the people trying to work them don't know how to operate them. And it is probably the most annoying thing I've ever experienced in my life. I work part-time for Wake Forest University Athletics Department as a disability services consultant. It is literally my job to point out where there are accessibility issues, that sort of thing. All I will say is that they've used probably 2 or 3 different bus services now, and they always have the same issues, and it's baffling. So, I don't know exactly what I'm trying to say other than to say that things are going to change and there's no way that you can keep up with it. So especially with a definition like assistive technology, you need to make it as clear as humanly possible that there is no way to make an exhaustive list, and it will be an ever-evolving thing without needing to rewrite the service definition every 3 weeks, which is probably what you need to do.
So some of the feedback we've gotten regarding that is under assistive technology, is there's categories, and under each category there's a list of items, and it has been proposed to maybe go to just the categories versus the categories in the items.
Yeah, why does there have to be a list of items? I mean, other than your basic, again, health and safety restraints, is there any reason why you have to list anything?
There doesn't need to be a list in our, if we move to resource allocation or support accounts or individual lists, if we make that move, you do not need those lists because they can be limited in other
I
ways.
think it would be limited by a dollar amount.
Right.
Of course, we want it to be, back to the safety thing, but, you know.
And then it could just become just the broad categories, and there's a lot more flexibility in what you can do. Because lists are utilization management tools. That's
Sure,
what
I
they
mean,
are.
that makes total sense in the system you're in now. I'm just thinking what we're trying to do going forward, that doesn't really lend itself to it.
Right.
You might just at the top of all lists, since this is the 3rd conversation on lists are overly limiting, you might put at the top of the list, which may include.
But then you
Well, actually, some of the lists do say that. I think they do say that.
Get rid of them.
But not limited.
Maybe we should say that
Provide education.
there is no list here, but you can check on.
Such
you can figure out a
as.
website. You can check on a website where these are kinds of things that might be, and that you could evolve over time. You wouldn't have to tie it to a definition. You might do that.
How would?
But then would that
Just
become,
that
sorry.
work with the feds.
Okay. I was going to say, would that then become another place for your departments
Yes.
to use as a resource?
Well, not
I
only that,
mean,
you can't do that, you cannot do that, I'm sorry, Dave, not to correct you, because you are
No,
the
you can correct it.
Dave, but.
You are the Dave.
No.
The Dave.
That's a wonderful title.
The Dave.
But that's not gonna fly with CMS, that you're referring back to something that nebulous, it's either in the
No.
policy or it's not.
No, I think it's in the policy or not, but I think what we could do on our website, could do things like, you wouldn't have to put in a policy, but just say, as you're looking about, these are the things that seem to be, people are using. I mean, you could do instructive things to help people understand.
Honestly, I think if you have a budget amount and you,
Yeah,
again,
I don't care.
I mean, what do I care what they spend it on something? If you
But
wanna
Dave
spend this
don't
money
care.
on the Kindle, for instance, then you may wanna think about how much you budgeted for day supports, but isn't that the whole point of an individual budget?
I have one more suggestion, and this is for Wake Forest, that perhaps they should have a vehicle adaptation specialist.
Yeah, I'll get
Oh, there you
on
go.
that in making that suggestion.
Then we'd have one to go to.
Yeah, there you go.
Of course,
I
co-create.
can't
And I gave
exactly
Mike
work in a
there.
garage.
But I think Carol makes a good point too. Whenever you put something out there, whether it's meant as a suggestion or not, people start taking that to the bank.
Absolutely.
Yeah.
well, and what lists evolved a million years ago, however many waivers ago, and we kept adding and adding and adding, and it didn't serve the purpose. So if you start with a really good definition, that should suffice. And as you say, if we're going towards more flexibility and people owning their own resources and budget, that'll work.
So it seems like
I was just gonna add that, so one of the things that we talked about in the care management group is a really strong guidebook for consumers and families, not a technical manual. It's all technical for all the techie people that care about that stuff, but that really does a good job of really explaining things.
Yes.
That
That's
is sort of
really
the book
necessary.
version, if you will, and there's lots of great mediums you can do that for people that don't read, that, you know, so they can hear, that would give folks an opportunity to be better educated about all this cost, rather than just, you know, having a technical manual that's hard to use for the person not working in the system.
It requires a position called Innovations Technical Director.
Right, right. Absolutely, you know, designated person to be the expert on the manual. So that would be, my recommendation is really looking at, rather than putting all that stuff in policy to guide or educate or get people to learn or understand it, is to really come up with a really good handbook that's practical for use by families and consumers.
That is,
I was just gonna say one more, so it just seems like this one, the overarching is the list, and I have to say it one more time, EPSDT.
Yeah.
It's,
how does this impact,
I'm right there with you.
in the equipment piece? Okay.
So I wanted to just say thank you to Wes for figuring out my technological deficiencies and managing to make this straight. We appreciate it.
Yeah.
And you
That's why
guys
everyone thinks I'm green. I'm still not.
I think you guys did a really good job breaking down these definitions into concepts. I'm assuming what you want is that, so we're going to get Kenneth send out the actual full definitions to everybody, so hopefully everybody receive those. And so, you know, I think that you hopefully have gotten a lot of good notes to take back to your group and your local and communities from this conversation. You want folks to go ahead and send you additional information as they share with the groups they're representing. What are your expectations and what's kind of your...
I think what we'll do is probably, we think by Tuesday we can flush out the timeline. So we'll have it completed when, because we're going to work on them in those pods. So you guys can get all that feedback in kind of in a systematic way, so we can organize it and work through, but we should be able to get that out by Tuesday for sure.
Yeah, the pods he's mentioning, like the choose where I live, how I spend my day, those categories, that's how we're going to look at the definitions. And the first two that we were targeting for is to have feedback by December 19th.
Right.
And I'm pretty sure that was where I live and how I spend my day.
yeah.
So those will come back to this group then?
Right.
Okay.
Well, that's the feedback date, and then we were going to bring the actual final drafts to this group in January.
Okay.
Very early.
Yeah, so we're looking for any additional feedback from those two categories by December 19th. But kind of for us to our timeline that outlines all of that.
Can I go back to something that Cindy and a couple others mentioned very early on, and it has to do with where I live and how I manage my services and how you think about respite and how you think about community supports. You talked about culture change, and if you look at the research, culture doesn't change overnight. It doesn't change after one training. It doesn't change after a year. It's a process. It takes at least 3 years for you to start seeing a change in culture. So all the great work in here that's being done and all the educational efforts that are going to be put out there, I think there needs to be a recognition so people don't get frustrated saying, oh, we developed this new service and people aren't using it or they're not using it right. It's going to take years. It may take by the end of the next waiver cycle for you to start seeing change. You don't think so? But I just, you know, we just, but I mean, you should hopefully start seeing incremental changes, but don't look for a sweeping change in the system or else you'll be setting yourself up for disappointment. It takes, it'll happen, but it just takes time. My parting thoughts for a Friday afternoon.
However, the more intentional we are in trying to facilitate that system change, the more likely it is that we will see any.
And I would also say that I don't think that this change is occurring just now. I mean, this has been coming over time before now, I think.
Yeah.
I hear what you're saying, but I don't think it's starting out of this group and this effort. I've been here 5 years and it's been growing towards this that entire time, so I think that's part of your incremental change.
Well, and one thing that will have a bigger influence on that than the whole time I've been in the system, which is about 22 years now, is that there are local stakeholder groups talking about it. There's this group, there's all these professional groups. I mean, it's being talked about all over the place in terms of developing it. So it's not just in isolation up here in DMA or DMH or wherever. It's a whole system. You want to be engaged and you're paying attention, you're engaged. That's what I think. And so, I agree with Carol, what she's saying, it's going to take a long time, but I think the engagement strategy that is being used here is probably the best I've seen so
That
far.
is the nicest thing you have ever said.
Mary's got that on record.
I do come with it once in a while.
Every 3 years.
Every 3 years or so. Like one nice thing. You don't get another one until 2017.
But think about how much more often it is than Jesse.
That's right. Yes.
It's limited like the waiver.
It's like limited.
One time every waiver.
Once in the lifetime of the waiver.
Service, yeah.
You change that, I'll change my policy.
I did want to piggyback off of that really quickly. First of all, I echo those sentiments wholeheartedly. There's one slight caveat, and that is I've been hearing a lot from across the state that there are various MCOs who would like to be more directly engaged with on a continuing and ongoing basis. So, like, for example, we get sent, revised service definitions and, minutes of what we're talked about and all that kind of thing. And I think this is more a general thing, but I think that sort of ongoing communication more diligently with various MCOs across the state would probably go over really well from some of the feedback that I've been getting.
Any other final comments? Anything you want to say, Dave, that didn't get said when he wasn't here before?
No, I think what we didn't necessarily do is, just so that conclusion is, this is it at this point, right? So if there's something else that needs to be proposed in terms of a new service definition, now or never. Like, we talked about the medical, however we want to call it.
Healthcare coordinator.
Thank you, my brain breaks at this time of the day.
What you might want to say, so do you have something in mind, Karen? Because if you do, maybe we need to put you on the next agenda.
Fred might have something
There
in
you
mind.
go.
Yeah, the questions come up about ABA.
ABA is going to be outside the context of this conversation, only to the extent that we are going to be working on a definition for it. And that'll involve its own state plan, its own definition, its own rate structure. It's going to be not separate from this group in the sense that nobody else has like a say in it, but it's its own beast. So, and it's under development. So I would say if you want to talk about something new, it'd be in addition to ABA.
So it's a B service, right?
It's a B service.
It,
We won't tell you.
yeah, I don't know that decision's been made, frankly. No, I don't even think it's a secret. I think it's just that it's in the very, so we are, I think that within the next, I think early in the year, in January or so, if you guys are interested, we'll be talking about who's gonna be sitting on that stakeholder group. I mean, no, you don't wanna be on it? You don't wanna be on it? That I can't believe.
We have that on record here.
Well, we'll put something else, cause
I'll point out.
but yes, that is a definition, it does need to be discussed,
Yeah.
but that's a bigger beast
Because
than
to your
here.
point earlier about the true skill building activity, that goes away under this waiver and becomes part of that blended service definition, so that one-to-one kind of stuff like you would do under ADA. You know what I mean? So,
Real skill.
the true down under building, skill building, it's not English.
Would there be something else besides ABA? I mean, and then medical navigator, which we kind of talked about.
And like something that's a different level of the consultative, I think, that would allow kind of a Q-level staff to do some training and maybe skill building.
Under the SCS and the primary crisis.
Somewhere, yeah, somewhere we need.
You could almost add some of the medical pieces around the specialized
Right.
consultation.
Yeah.
What about transportation? I know for at least in our really rural, non-medical transportation.
Non-emergency medical transportation,
Yes.
that's a tricky beast, Cindy.
Is it? Because it's saying some states have in that service center home care service.
We used to
Yeah.
have.
Embedded in some of the services now.
Yeah, it's still,
It's
It's
very
embedded in
limited.
services.
It's embedded in
today,
certain
it's
services,
said
like your app, for
transportation is
instance,
supposed-
sure.
Right.
The rate setting and the rate setting piece of that is gonna be tricky. Honestly, I don't know if you really wanna go down, I mean, and this is just, I'm throwing this out there, I don't know if you wanna go down that path with the pretty major change you're already talking about making in the budgeting system. It may be something for a future waiver to include kind of thing, because especially in a state with as many rural counties as this one, I think 48 out of the 100 counties fall under the rural definition. I don't know if now's I don't by any means take away from it as this pretty huge issue. It may be more than your plate can handle right now.
We need non-medical Uber.
Billable.
Funny.
Any other parting comments? We will have rate setting. I wish Renee was here because I can't remember. It's one of the 2 December sessions. It is December 19th? Okay, good.
Yeah, I'll look at that email, yeah.
So, yeah. So if you have any other questions surrounding that, send them in because Roger will be tailoring his answers to that. Anything you want to say, Dave?
Nope.
Thanks for showing up.